Hello, friends. I'm Dr. David Brown, interventional cardiologist, founder of the Baylor Scott and White Heart Hospitals, and your host for Heart Talk, the podcast about all things heart that we hope will become number one in your hearts and minds. Today, we're thrilled to be joined by Sue Krais, our Chief Nursing Officer and Vice President, better known as Czar, of Patient Care Services at the Baylor Scott and White Heart Hospitals. Sue is the lead nurse executive for the Heart Hospital system and oversees multiple service lines, including Inpatient Nursing, Operative Service, Clinic Hospital Outpatient Department, which is known as HOPD, and Cardio-Pulmonary Rehabilitation.
You're listening to Heart Talk with your host, Dr. David L. Brown. Dr. Brown is an interventional cardiologist, innovator, and co-founder of the Baylor Scott and White, the Heart Hospitals in Plano, Texas. He now serves as President Emeritus of the Heart Hospital's medical staff. And now, here's your host, Dr. David Brown.
Let's start with, where'd you grow up?
I grew up in Kewanee, Illinois. It's a small town, and it's called the hog capital of the world. Very proud of that. But it's a small farming community, and just I had a wonderful upbringing there.
Okay, so we'll come back to the hogs, but I also know from some of our, deep conversations that you actually got to be Dr. Sue Krais and got your PhD in a little bit of an unusual format, starting back with your RN. Mm-hmm. Can you just take us through the RN bit up through the PhD?
Well, I've got my diploma back in 1988. Believe it or not, that's a long time ago. And now they don't have diploma schools. You have to get your associate or your bachelor's. And my school is no longer there. I did not start to go back to school until I came here to the Heart Hospital. And the reason being is I was pretty much told that I was going to have to be a manager. And I fought it. I cried about it. I didn't want to be a manager. I didn't want to be a leader. But I ended up embracing it, and I had to go back to school. So I went back to UTA and got my baccalaureate, and then just continued to roll. Once you're in school, you don't want to get out of it. You're in the mode. So I went and got my master's, and then I decided to go get my doctorate and achieve that in 2023. But it's a big change from when I first went to school to when I went back to school. It's 23 years that I had to go back and do algebra, which I don't wish that on anybody.
We're glad you did, and we're proud of all the things you did to get our Dr. Sue Krais as our amazing leader of our patient care services. So going back, I also know you're a great athlete. Tell us the sports you played. What sports did you play?
I don't know if I would be a great athlete. I think I was a good all-around athlete.
How about a good athlete with a great arm?
A good arm. I did play softball for about 18 years. I was Batgirl for a long time. My parents were my coaches. I played softball, volleyball, basketball. I did a little bit of track, and then I played golf for fun, just because we like to play around in the golf carts.
What position did you play in softball?
In softball, I played catcher and outfield, so I was center field.
That good arm.
I had a good arm, and I played. I did some traveling. I played for another team for traveling, just to be a catcher. So that was a good experience to play with another team that you didn't know the people.
Well, that makes Mark your number one fan because of the athletics and all his winning teams that he has to have. So being a star, that helps the Heart Hospital a lot. As you slow down some of the athletics, you also kind of moved into hunting and fishing?
Hunting and fishing. I love to go fishing, but I love hunting. My husband that I have now, Joe, that was one of the things that he loved to do is go hunting. So that was one of the first things that he introduced to me. And we go out to the hunting lease and we go hunting. I love to hunt the hogs. I do not shoot at deer. I leave Bambi for him, but I do like to get to the hogs, those little rodents out there.
And you guys eat the hogs?
Not most of the time, no. They're too large, and most of the time they just need to be thinned out.
That's good for the Arkansas Razorbacks. I also happen to know you have 2 dogs and a cat. Tell us about them.
I do. I have a Argentinian Mastiff named Bubbles. If you have not seen a Mastiff, she looks pretty ferocious, but that's why we named her Bubbles, or Joe named her Bubbles. And then I have a Weimaraner Roxy. She's a very needy dog. And then I have a cat named Steve. He's a tuxedo cat, and he runs the whole ship.
3 kids. Where do they go to school?
So I have 3 children. My oldest is currently working with Plano DPS as a dispatcher. I have my middle child, Hunter, who has graduated from OSU. He has a degree in philosophy, so he's interesting to talk to sometimes. And then he works at a law firm. And then I have my youngest, Savannah. She is down in Cedar Park. And both Thord and Savannah are recently married, and Savannah works with autistic children.
So, but one went to Oklahoma State. The other 2 went to A&M in Arkansas?
My oldest didn't go to college. He pursued other avenues, but my youngest, she went to A&M. And then I do have acquired 2 boys, step boys, with my marriage. And Taylor went to Arkansas, and Bo is now studying to be a police officer.
So in all that, just on football alone, your favorite college, pro, either one?
Well, college, we like watching the college games. We think they're much more entertaining. And so we watch probably any kind of college games. Saturdays are our college football games. So we'll watch OSU, we'll watch A&M. I'm probably lean towards more OSU. I went to a lot more OSU games than I did any other football games. But it can be a little bit contentious in the house.
Well, you anticipated my next question. Which one was your secret favorite? So let's shift over and talk about why we're here. Talk about nursing at the Heart Hospital, about our nurses, and why we believe it's really quite different from, I'm going to say, not only most other institutions, but effectively just about every other heart hospital or heart institution in the country. What's different about it?
Well, I love the question because I think about it, and I think back at the time when I first came here to the Heart Hospital. And I actually came in 2007 when they first opened and took a look at the Heart Hospital. And, they were not quite what I was ready for at that time. The blood bank was still over across the street, and I'm like, I'm not running across the street to go get blood. But I came back 2 years later, and I was excited to join the team. One of the things I found so interesting is everybody was so happy. People looked at you in the face. They were happy. They addressed you. And, from an old stodgy nurse, after being several years on the floor, I was like, is everybody on Xanax or what's going on here? Because everybody was so, gracious. And, that just resonated on the floors. And you could see that with how people react to patients and how they treated the patients. And I think, that just goes back to, what you've always talked about is quality. And when you provide that quality care, that interaction with the patients and the patient experience, it goes a long way. I think that makes a big difference on other hospitals where I've worked. The focus on the patient experience, the patient quality. I haven't felt that. I don't think I felt that resonate all the way down to the floors like we do now. And I think the floor nurses carry that moniker of quality and patient experience.
That sort of leads to a concept that you and I have talked about a great deal, of a desire that I had, that we had at the beginning, to make the hospital a different experience than just a hospital. Mm-hmm. And fundamentally, we have labeled it as a place where we have guests rather than patients, and it's a guest experience, and it's basically a hospitality experience in our mind, the way we're trying to present it. So we're trying to deliver the care, but at the beginning, one of the things I said was, could we try to mimic what you would feel if you went to a luxury hotel? And I used different examples of it, which led to the concept that when we admit you to the hospital, can we put you in not just a room, but a suite? Can we build a suites?
Mm-hmm.
Can we put you in that suite? And then can we leave you in that suite instead of moving you from getting admitted, going to the ICU, going to step down, going back to the floor,
Mm-hmm.
being moved 3 or 4 or 5 times in a hospital? Can we put you in a suite and leave you and your family there the entire time in a process that we've now called the universal bed concept?
Mm-hmm.
I think it's been spectacular for the patient. You want to talk about how it's been for the nurses and
Mm-hmm.
how all this has gotten us down the path?
It's a unique concept. I think from an old ICU background, when I first entered into the heart hospital, you really have to believe it. You have to see it, you have to work it, you have to sense it, and you have to see the outcomes. When I first started as a manager, I sold, when you try to hire new staff, you tell that new staff person what your floor is like. And I tried to sell it as like, this is a CVICU, and it really isn't. I had to learn the hard way because I lost a lot of staff that way. And for nurses that are hard-nosed, I just want 1-to-1, 1-to-2 care. That's all I want to take care of. This is probably not the place for you. You have to be engaged with what is going on with the patients, whether that they're in CVICU or whether or not they're in telemetry status. And you have to care about how they're going to flow throughout their hospital stay during that time. And it takes a unique individual to want to do that. I think once I started to change my mindset of how to sell this to nurses when they came and they interviewed, then I became more successful. You had to tell them exactly what this hospital means. But then they saw when they got here, they got to see how patients evolved and how they got better. I know from my experience being in an ICU, you saw them in the ICU and then you never saw them again. You transferred them out. You never saw them go home. You didn't really establish relationships with families. And if you really care about nursing, you care about patients and their families, this is the place, and this type of model is the best model for that. I think you get a much more of a reward for the care that you provide when we have a model such as this.
We started the hospital with the concept quality wins. If we do that right, everything will follow.
Mm-hmm.
We applied the same thing to nursing care. And I feel like not only have we won with that, but you've also won virtually every award there is. Can you just talk about that a little bit?
So we were just awarded the Comprehensive Cardiac Center, which is we're the number 21st in the United States to achieve that award. We're embarking on our 4th redesignation for Magnet, and we're going to encompass all 3 heart hospitals in regards to the Magnet document. And so we're sending off that document here in October. We're really excited about that. We are a Press-Ganey Award winner for patient satisfaction, 27 times for Pinnacle, and as well as Guardian Award in our emergency departments. And then we also have our ELSO, our ECMO care. We are a gold standard for ELSO for ECMO care. We have achieved that, and we're going to go for our platinum. We've got all these other certifications for heart failure, LVAD, palliative care, PHAC, and then we just had the Beacon Award on the 2nd floor.
Do you have any ability to explain either the significance of Beacon or who it actually comes from? And maybe you don't. I don't know.
Well, it comes from the AACN, American Association of Certified Nurses. It's really to highlight the care that they provide on that specific floor. And it's something that every single one of these floors can highlight. They do an amazing job. But they really take ownership of the care that they give on the floor. If we have a bad outcome or if something untoward happens to the patient, we are doing deep dives to find out what happened, what can we do better. Just to give you an example, we saw an increase of hospital-acquired pressure ulcers. And some of that comes down, in the investigations, it came down to the sheets were not right. That's something we can fix. The sheets are too tight, or they don't give, and they give too much abrasion to the skin, and that it's causing pressure ulcers. So those kinds of things is what we really take pride in, to get down to the nitty-gritty, the deep dive. And and I think that follows in the footsteps of what we've learned with the physicians as well. When you perform the phases of mortality meetings, I've learned from those, and I just want it to be replicated from the nursing standpoint. We should be able to provide that kind of a level of deep dive as well.
Well, and I think you've done that in nursing. It's what you touched on is the piece called PACMA that we learned some years ago, really from Michigan, and it's the concept, obviously, of looking at what caused immortality. Was it the judgment before, the planning before? Was it actually getting to the operation pre-operatively? Was it the operation itself? Was it post-operatively, or was it after the fact? And you've utilized that for the nurses now, right?
Mm-hmm. Well, we take a look. Most of ours are post-surgical anyway, but we do take a look at, did the nurses follow the orders? Did they what critical judgment did they utilize during their care of the patient? Could they have done something different? Could they have something better? And some of it, when we have some things that go wrong, is even just a process that's wrong. And we take a look at the process and see what we can do to make sure that they have the guardrails and the boundaries to provide safe patient care. And if those guardrails are not there, then we're gonna try to fix those for them. I would have to say we're not we try not to be punitive to this nursing staff. I always say, if we're doing a root cause analysis, or if we're doing an incident review, it's not to find cause that you're the one who did something wrong. It is really to find out what went wrong and what can we do better.
We talk about zero mortality in heart surgery at the hospital, and we've made a real effort to move in that direction in things like ISO-CAB or ISO-AVR, just a physician doing an operation that is only coronary bypass grafting, or only aortic valve replacement, or only mitral valve repair replacement. And in those things, because they're not combined operations, we've gotten so good and maybe reduced it to a simplicity where we really have a chance for zero mortality. Having said that, this push on our physicians is basically carried over to what happens after the operation.
Mm-hmm.
And I've said for a career that we can have the best surgeons in the world, but if we don't have the best post-op nurses, the best ICU nurses, and the best ICU care, it doesn't make any difference, because we will have mortality in that process.
Mm-hmm.
So it's a combination of that, and maybe as you talk about that, touch on the relationship of the nurses with our physicians.
Well, I think you have to have a wonderful relationship with your physicians as best as you can. And I've always, being an old nurse, I'll go back and say, that's not an old nurse. I'm not so old.
Yeah, you're not an old nurse.
But when I was practicing at the bedside, you had your surgeon and yourself. You didn't have a hospitalist. You didn't have a nurse practitioner. You didn't have an intensivist. You just ended up calling the surgeon. And I think we're missing something because of that. We have a lot of other layers now that are in between, and sometimes then the messaging doesn't get as good with our surgeons as we would like. And so I've always tried to strive to the nursing staff to please call the surgeon. Get the surgeon, the practitioner who actually performed the procedure. You need to get in front of them to discuss what's going on with the patient. And in essence, you're going to learn something from them as well. I learned a great deal with having those conversations over the phone, or even rounding with physicians, that you have a discussion of what went on with the patient and what's going on. And I think we were missing something with that. And I think that's just the evolution of healthcare. But I do think we have a great bond with our team. We have, our leaders round with the staff, or they're around with the physicians. They try to get in front of them. We have nurses that engage in different various meetings with the physicians. So we try to keep that open dialogue with them as much as we possibly can.
I'm going to talk about ERAS just for a second,
Mm-hmm.
and then maybe ask you to explain it and talk about how it's impacted nursing care and patients. I was sort of death from above on people going home as early as they could, long before sort of my famous line of "country was cool," and I wanted people to be able to go home, a long time ago, as soon as they could after they had coronary intervention, and we kept shaving the days off that till it got to be the next day, and then I started trying to ensure that we could safely send people home the same day. And then following that with not only intervention in cardiology, but with parts and pieces of electrophysiology, whether you had a device change or whether you had a pacemaker, and could we safely do it and get you out of the hospital, certainly in less than 24 hours or even same-day discharge. We even got to the point where replacing your aortic valve with a transcatheter replacement instead of open heart surgery, we can send you home the next morning. You have less than a 24-hour stay oftentimes. And so this was very important to me, partly because I felt like the longer you stayed in the hospital, the longer we had a chance to make you sick, the longer we had a chance to make something go wrong. And you also, if you're a smart physician, you can fix all that. You can send them home, and you don't get calls at night from the nurses because they're not in the hospital.
True.
And the truth is, I've often said, if you assess the situation right, I generally believe that the family is going to pay closer attention to the patient than we are, no matter how good we are in the middle of the night at 2 and 3 and 4 a.m. So I spent a long time doing that, and I feel like the world and the system is coming after that now, and I think part of the program is this ERAS program. Can you talk about some of the fun things? You even had a contest about ERAS as a developer. Tell them what ERAS is and tell them what you're doing with that.
So ERAS is enhanced recovery after anesthesia. And we primarily saw this, at least in the system, with our colorectal surgeries or our abdominal hysterectomy surgery. So CV surgery was really not on the target or the gamut for ERAS. And so we did introduce that here. We introduced it on the 5th floor, which is one of our Cub model units, and they receive open hearts. We introduced it with a couple of physicians, so they had some ownership of the order sets and making sure that those were all filled out. But it is really to kind of have it's a guideline. It's a guideline for nursing care for us to follow, to make sure we hit those mile markers to get them out of the hospital sooner, but also to enhance their recovery. We want to make sure that their pain is taken care of, that they're not as nauseous, and that really even starts at pre-op. They are given sometimes a carbohydrate drink. They are asked to exercise. You stop smoking. You need to be try to get themselves a little bit more in shape. All the way through procedure, and then post-op, we get them up. We get them moving. They have to walk certain feet. We start advancing their diet just to get them ready to go home. It's not good to lay in bed for 5 days and then expect to go home. You need to be up and moving. So we are moving patients immediately after they're extubated, probably within 4 hours after they're extubated. They're getting up to the side of the bed, to the chair. We're trying to get patients out into the hall the next day, getting rid of all their lines, and just moving them expeditiously through the system, not just primarily for us, because I want the beds. I really do need the beds, but really because it's better for the patient. And we even saw that when, the ERAS has done a great job. We've rolled that out. I think it's gone now 2 years that we've rolled out ERAS. We did have a contest to kind of make sure that all the nurses got on board with it. They actually had, I think, a scorecard, and they had little pictures up on to move people across to see who did the best job. And it's just anything that we can do to kind of spur their interest and get them engaged is what we want. They actually ended up going to a basketball game afterwards. I think they went to the Mavericks game. We got them tickets, and they got a sports session there. So it was very fun.
So fundamentally, to me, these are really checklists. And we've started checklists here in numerous places, including tavern, the operating room, things for defibrillators, pacemakers, and certainly this prospect of getting people home sooner guidelines or checklists that fundamentally make sure that everybody's doing the same thing, as you said. And it's nice to say that, nursing's a profession, medicine's a profession, and I don't need to be told what to do. I know how to do it. That's why I train that way. Unfortunately, when you get this many people involved, it's still a bell curve. And we did have to narrow the gap to make people understand there are better ways that somebody's doing something than every individual. And I think we've done that with the early discharge programs, with ERAS, and with fundamentally the nurses getting everybody on board, and even dragging our physicians who are somewhat reluctant to say, well, okay, I don't want my patient to go home yet. Okay, well, they're walking around eating, they're dressed, they're in civilian clothes, they need to go home. So I think that's been a big bonus for the patients, the care, and the hospital, obviously.
Yeah, and we're replicating it now with vascular. So our AAAs, they are on an ERAS program, and I think we're just going to continue to see that evolve. And it is beneficial for the nursing staff to have something that they can follow every day, and then we can teach the patient and their family members what to expect. So they should know on day 2, this is what you should be doing on day 2, so they are prepared and they don't have a lack of knowledge of what their stay should entail.
And when you say that, are you talking about an open AAA, or are you talking about transcatheter AAA?
An open AAA.
Yeah, you're talking about an open AAA because they're going to be here a little bit longer.
Yeah.
It reminds me of a story that when we first opened the heart hospital and we were doing things at other hospitals, as we started to come over here and do cases, the very first sort of transcatheter AAA stent graft that I did, fundamentally, do with closure devices. So we get a stent graft in, the aneurysm is reduced. Fundamentally, the closure devices are a ripcord where you pull it, the artery's closed. And so the patient goes back to their room, and I have these orders that, look, I want them up after 6 hours, I want them walking around, and oh, by the way, they're going to go home tomorrow morning. Well, this was, a good while ago, not quite 20 years ago, but it was long enough ago that the nurses were just sort of almost unknowledgeable, uncomfortable with what was going on. They just had surgery. Well, yeah, they did, but it's a different kind of surgery. So we've got to move through that. At the time, it was a little bit of a firefight of, well, you can't do that if they had surgery. They had anesthesia. Let's get them up walking, eating, moving. And in short, the transcatheter piece of that went home the next day.
They did.
And now that's standard care, right?
It is. I remember when you did your first one here. I was actually on the floor. I was not taking care of them because I was working on a different floor. But we did have to have a lot of education go out to the nursing staff, and it's okay to get the patient up right after surgery. You can take out the arterial line. You can do these kinds of things, because it was more driven on the protocol rather than I'm waiting for the next day for the physician to round to give me the orders to make sure that I can take this stuff out.
Right. What's next for your nurses? What's next for the hospital in the nursing arena? What can we do better? What can come along, or what can we force to help make this better?
I think, just being very competitive with the markets is probably one of the best things to try to keep nurses here, but also continue to develop our culture. And we do have a very wonderful culture here at the Heart Hospital. I think going back when I first met Mark Valentine, I was like, I never met a president in any other hospital that I've ever worked. Most of the places I've worked, I never had met the CNO. Getting in front of those people, making this more of a family as much as we possibly can, is probably essential to keeping our staff happy and healthy here.
I feel like our nursing staff is so far advanced in terms of the things we talked about related to the universal bed, related to the patient-family interaction and the closeness of it and the relationship they develop, as well as the interface that they have with physicians. I think, what you've done to create that culture that you talked about is exactly why we're so successful. And at a place where, as you noted, I think almost every nurse here couldn't ask for a better place to work. if somebody wanted to double their salary, they could probably find a reason to go work somewhere else. And we've had that happen a great deal with how good our nurses are, with how well you've trained them, with how well you've led them. And as a result, sometimes we've lost nurses. We've gotten better about being able to match certain raises, but it's not perfect. And as a result, you keep recruiting new nurses and these young nurses who are as good as anybody we've ever seen. So I think the growth is there. I think the same quality is there. And I don't think there's any magic bullet that's going to sort of come up with the answer to my question.
It's hard. We're very competitive in regards to tuition reimbursement and to continue education. So though I don't like nurses to leave us, I know that there's growth out there for them. And if they want to, I would like to encourage them to do that if that's what they want to do. And we want to be able to provide them the resources that they can. One of the great things I think we have here is the schools. I've lost a lot of my bedside nurses to our perfusion school.
Right.
And our perfusion school is a wonderful school, and it's taken our majority of our ECMO nurses. We do have a little bit, it's not a ladder, but we do have nurses that they have to be LVAD specialists to become an ECMO specialist, and then from an ECMO specialist, then they usually will go and apply to be a perfusionist. And it's a little bit of a way that they can build their career and professional growth. And we've lost a few of them to that, which is great. I love seeing their growth. I actually was at Arkansas Heart just the other day, and I saw one of our nurses there who graduated from the perfusion school, and she came out and gave me a big hug, and I just love seeing her. And it was great to see that growth on her, and that the Heart Hospital was able to provide that.
It demonstrates, I think, the quality as well as the culture that you've instilled here. I think, as you know, from some of our conversation and interaction, I continue to be amazed at your leadership of both the nurses and also the culture in the hospital, the culture that our nurses bring to that patient care. And as that continues to be the high point of our patient care success and patient care quality, I can't thank you enough for everything you've done. I really admire your leadership and what you've done for the culture here. Thank you very much for joining us today. Thanks for coming.
Well, thank you for having me. I enjoyed my talk here with you.
Thanks.
Thank you so much.
Appreciate it.
Views and opinions expressed by Dr. David Brown are his own and do not necessarily reflect the views of the Baylor Scott & White The Heart Hospital or any of its officials. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of any of them or any entity they represent. The information provided herein is considered educational and should not be used during any medical emergency or for the diagnosis or treatment of any medical condition. A licensed medical professional should be consulted for diagnosis and treatment of any and all medical conditions. Call 911 for all medical emergencies.